Annual National Pancreas Foundation Fellow Symposium. Before we get started, let's review some webinar tips to maximize your experience using your webinar command bar found at the bottom of your screen on most laptops and desktops. The symposium has several panel discussions with an opportunity for you to participate. We'll use the Q&A panel, which opens by clicking on the Q&A icon on the command bar. With this open, you'll be able to easily submit questions. You can also upvote submitted questions, which pushes the most popular questions to the top of the list for a moderator. To upvote, click on the thumbs up icon next to any question in the Q&A panel. Your video and audio are turned off when you enter the webinar, and you will not have the audio-video icons typically found in a Zoom meeting. However, for the panel discussion portions of the symposium, we encourage you to ask questions verbally. Here's how: using your audio. Click on your digital raise hand from the command bar or by opening the participants control panel, and our tech crew will turn on your audio. The moderator will call on you by name or simply announce yourself before asking the question. Keep in mind that audio systems are very sensitive, so when you are not speaking, turn off or mute your speaker to prevent accidental disruptions during the live program. The chat panel will also be available for one-on-one conversations with panelists and other audience members throughout the symposium. Be advised, questions placed in chat will not be part of the panel discussion, so be sure you're using the Q&A panel for your questions. You can easily scale the presentation and speaker sizes to create your best view by sliding the bar located between the speaker video and the presentation slides, left or right. If your internet connection goes down or you need to rejoin the program, use the same link from your email. This will often fix any audio issues you may experience. At the bottom of the screen, we have listed technical support numbers to text or call. You may also reach technical support using the chat. Send a private chat message to tech support in the chat list. Lastly, don't forget to use our hashtag NPF Symposium for those of you on social media. Thank you. And to start today's symposium, please welcome Dr. Dana Andersen.
I think you're on, Dana.
Good morning. I'm Dana Andersen, and I'm honored to welcome you to this 15th Annual Fellows Symposium of the National Pancreas Foundation. This is a program that began in 2006 and has since more than doubled in size. The first symposium hosted 19 fellows. I think we have at least 51 fellows and junior faculty registered for this year's symposium. So we welcome you all. The attendees come from all across the country, as well as from South Africa and Pakistan. So this is an international group, and we're absolutely delighted to have you here with us today. Next slide. We especially want to welcome John Lieb and Tim Gardner. These are two of the anchors of this symposium. They were both fellows at the original symposium in 2006. And for the next 15 years, they've helped guide this symposium and develop the program and help to make it stronger and better and more interesting for all of the attendees. And you're going to hear from them today and tomorrow. So we are especially appreciative of their input. Next slide, please. So the purpose of this symposium is obviously to promote awareness and extend the knowledge of pancreatic disease, particularly for those graduate trainees and early faculty members who are pursuing careers specifically focused on the care of patients with pancreatic disease. The symposium is organized so that our speakers and mentors can actually speak informally to the attendees, which means that you are absolutely invited to raise questions and to post comments in the chat section. As a virtual meeting, it's a little awkward because you can't simply raise your hand and interrupt the speaker, but all of the speakers are happy to be interrupted. And the whole purpose of this is to create a dialogue between the speakers and the attendees. And ultimately, we hope that pieces of information that are contained in this symposium will really influence and improve your treatment of patients with pancreatic disease. Next slide. We also want to just make you aware of the fact that next year we expect to be back to an in-person format, and we already have arrangements made to have our 2022 Fellows Symposium in Dallas on April 1st, 2nd, and 3rd. And there'll be more details about that, but we look forward to getting back to an in-person format. Next slide. We especially want to thank the people that have really made this possible with their financial support. And that includes AbbVie, which has been our principal donor. Next slide. As well as other companies such as Medtronic, Alcresta, Digestive Care, Sagent Pharmaceuticals, and ChiroClin. Next slide. So we have a busy agenda. We're going to start off today with some introductory lectures from some of our experts, and then break down into different sessions focusing on pancreatitis, pediatric pancreatitis, and tomorrow we'll continue with pancreatic cancer. Next slide. We'll also have some case studies that we'll present tomorrow with discussion, some interesting and challenging cases. And then finally, we'll end up speaking about partnership and research opportunities for those who want to pursue research in pancreatology. Next slide, please. So on behalf of David Bakelman, the CEO of the National Pancreas Foundation, our staff, and all of the folks who've helped to put this program together, we welcome you to this symposium. And I'm happy to introduce your first moderator, John Lieb. John, great to see you.
Great to see you too, Andersen. And good to have all of our attendees and faculty members here at the NPF.
I think you're muted. We don't hear you.
Can you hear me now?
Yes.
Okay, great. So it's great, Dana, also to be involved in the National Pancreas Foundation throughout the years and to be involved in this symposium. We're happy that you all are attending, and we have a very exciting symposium for you all today. Just a little trivia piece that Dr. Andersen and I met 20-some years ago as a medical student, and his division at Johns Hopkins probably also helped influence me in pursuing a field in the pancreas. So at this time, I would like to introduce our first session, and we have a really outstanding session here this morning. We always like to start the National Pancreas Foundation Fellows Symposium with a bang, with exciting speakers and really encapsulating what's important in the pancreas right away for you all to see and to understand. And we did that today as well. So it's an absolute pleasure at this time to introduce our first speaker, who is Dr. Christopher Forsmark. He really needs no introduction, and I could spend a half an hour talking about his accolades, but I really want to get into the meat of the pancreas. So I'll just say that he's professor of medicine at the University of Florida and runs an outstanding division down there and has done so for 22 years, where he's mentored whole generations of interventional endoscopists, pancreatologists, and gastroenterologists. And he's going to be talking today about what we know and what we don't know in the pancreas. So thank you, Chris, for coming here today, and we look forward to your talk. Oh, I just want to mention, I'm sorry, one more thing. Normally, as Dana said, this is usually a very interactive symposium, and there's lots of interpositions and interjections, which are fantastic. But at this time, I think we have to reserve our questions for the panel Q&A session, unless there's something pressing that comes up through the Q&A session. So thanks, Chris.
Thank you, John, and Dana, thanks. Yes, this is an absolutely terrific meeting over the years, and it's been such a useful enterprise to help young people develop and become new clinicians and investigators in pancreatic disease. I've been given the unenviable task of talking a little bit about what we know and what we don't know in the field of pancreatitis, which is quite a long list on both sides. And I'm going to also include a little bit about some of the things we know, but maybe we don't do quite as well as we should. Next slide. Next slide. Thanks. No, you went two. Back one. Thanks. So this is, for everybody on the call, this is a patient, a 46-year-old woman admitted with first episode of acute pancreatitis. Looks pretty sick on admission, tachycardic, a bit hypotensive, but afebrile. Oxygen saturation diminished. Expected findings on physical exam due to abdominal pain and dyspnea. And the initial lab test revealed hemoconcentration, a BUN of 32. White count is moderately elevated at 17,000. The liver chemistries are abnormal. An abdominal ultrasound shows gallstones, normal common bile duct diameter, and no common bile duct stone seen. So a patient admitted for a first episode of gallstone pancreatitis, at least moderately sick. And so I might pose some clinical questions to all of you. So should you order a CT scan now? Does this patient belong in an ICU? What would you recommend for fluid? How would you determine when you've reached your goal? Would you give antibiotics to this patient? Would you send them for an ERCP now? Would you offer some type of either of nutrition support like TPN or tube feeding? And when would you anticipate cholecystectomy? So these are clinical questions for which we obviously would like evidence-based and solid answers. Next slide. So as I was preparing for this talk, I went back to the first edition of Schlesinger and Fortran, a textbook that most GI fellows are familiar with. This is from the first edition, a chapter on pancreatitis, and I'll just point out a few interesting sort of things. First, they noted that this was an ill-defined collection of puzzling entities, which probably still holds true today. They noted there were characteristic imaging findings. Ours are a little bit different, but still we have characteristic imaging. They defined sort of what medical therapy is, and I'll point out that one of them was fluid replacement. They noted essential there on the lower left. NPO until the patient's pain-free, then feed him. Antibiotics used selectively, and that medical treatment was superior to surgical therapy. And surgical therapy on the upper right was really only indicated in a few situations. And even then they were noting that these early fluid collections and areas of necrosis shouldn't be operated on early if possible, and we should let the wall of the pseudocyst, quote, ripen, which I love that word. And then they noticed that there was patients that were much more likely to die and those that were much less likely to die, those with interstitial pancreatitis. And they noted that death when it occurred was due to either organ failure or sepsis. So much of this could be transposed into a modern day textbook of acute pancreatitis. Next slide. So when I think about managing these patients with acute pancreatitis, you sort of wonder, what is it we're actually trying to do? What are we trying to prevent? And if you read the literature, most of what's outlined as, or what's defined as the important outcomes are on the right of this slide, which is, does the patient develop organ system failure? Do they develop necrosis? Does the necrosis become infected? But what's really important, what's clinically important, and obviously what's important to patients is on the left-hand part of this slide. Do they die or not? How long is the length of stay and how costly is it? Is there a need for an invasive intervention? Does the disease recur? And what are kind of the long-term consequences. So much of the clinical literature focuses on the list on the right and not on the list on the left. Next slide. So as I was going through this, I made a list of the things that I was certain of back when I was in your shoes, when I was a fellow, which is more than 30 years ago. So here's some of the things that I was absolutely positive about as a fellow about acute pancreatitis. We knew that the Ranson criteria were highly accurate, but we also knew they were impossible to remember, obviously. And what do we know now? That these multiple factor scoring systems don't really outperform an experienced clinician. We thought back then that patients had to be NPO for prolonged periods. Now we know patients can be fed early. We thought then that really patients needed massive fluid resuscitation. And now we know that over-aggressive fluid resuscitation can actually lead to worse outcome in select patients. On the left, we thought that TPN improved outcomes, and now we know TPN is risky and not needed. We thought that prophylactic antibiotics were useful to prevent infected pancreatic necrosis, and now we know that prophylactic antibiotics don't work. We thought that infected necrosis required an urgent and open surgical debridement, and now we know that's not the case. And the more we can delay and let the collection become walled off, the safer it is with minimally invasive approaches. We thought that early RCP was really important in these folks in improving outcome, and now we know that in patients with gallstone pancreatitis, if they don't have concomitant cholangitis, the RCP does not provide any benefit. We thought we could wait a few weeks for cholecystectomy, and now we believe that you have to perform cholecystectomy, if at all possible, at the index hospitalization. And we thought that complete recovery of pancreatic function was what was going to happen to these patients. And now we know that a significant proportion develop either exocrine insufficiency or diabetes late. So as I think about what we know and what we don't know, certainly what I knew when I was a fellow turns out much of it to be incorrect. And even if what's on the right is generally correct, as your careers evolve, you will find that much of what I put on the right might actually be incorrect as well. So it's what we know and what we don't know is kind of a moving target. Next slide. And just a few examples in acute pancreatitis. So if you look back over the last at least 50 years and say what causes acute pancreatitis, it's alcohol and gallstones, alcohol and gallstones, alcohol and gallstones. But what we know now is there's a lot of other causes of acute pancreatitis. And the data on the lower right is from Daraj Yadav and Al Lowenfels. And the three different colors are three different causes of acute pancreatitis. Purple is alcohol, yellow is gallstone, and blue is idiopathic. And the far left in that slide is just all comers, all males and females. And you see that non-gallstone, non-alcohol causes are significant. And you can see that as people age, both males and females, this idiopathic or non-alcohol, non-gallstone group grows and grows. So there have been major shifts, I think, just in thinking about what actually causes acute pancreatitis. Next slide. So as we think about, treating that patient I presented at the beginning, what are we trying to do, or what are the possible treatment goals? We're trying to provide the best possible supportive care. That's stuff like fluid resuscitation and nutrition. We're trying to prevent this systemic inflammatory response and prevent distant organ system failure if we could. We're trying to reduce necrosis, that is, preserve as much of the gland as we can. We're trying to prevent complications, and if we can't prevent them, at least identify them and treat them effectively. We want to reduce mortality, reduce recurrence, and you can make other important treatment goals as well. But next slide. So what do we know and what don't we know? Well, there's a lot written about fluid resuscitation. You would think we would know how to do this. We have 7 randomized trials to guide us. They're all a little bit different. Some have compared goal-directed therapy, that is, you have some goal, let's say reducing the BUN versus just giving standard fluid. Some have compared rapid versus more gradual hydration. Some have compared different types of fluid like normal saline or hydroxyethyl starch, that's HES, or Ringer's lactate. And you can review these, but the interesting part of all of these trials is they're all underpowered, and none of them have provided what might call we might call high quality evidence. And I include a quote from a publication in Gastro a couple of years ago. We have no high quality evidence to inform us what to give, how much to give, and when to know that we've given enough. And I just put sort of a brief summation of these trials in that little chart to the right. Rapid versus gradual hydration, no big difference, although there were 2 trials that used very rapid infusion that actually increased mortality with more abdominal compartment syndrome. Hydroxyethyl starch made the outcome worse. And then the studies of Ringer's lactate show that that reduces C-reactive protein, but it's not even clear that that reduces some of the major complications or improves the outcomes I showed you on the previous slide. Next slide. So we don't have a lot of high quality evidence. What we do have are a lot of guidelines. And this is just a list of 5 guidelines giving clinicians like us information on how we might want to resuscitate patients with acute pancreatitis, the fluid, the rate, the timing, and the endpoint. And what I'll point out to you is there's significant variation across guidelines. So these guidelines are sort of the best we can come up with in terms of expert opinion, but they're not based on solid and strong high-level evidence. And I think that's one of the challenges when I think about what we know and what we don't know about managing pancreatitis is we don't have enough data upon which to craft data-driven decisions and guidelines. Next slide. And of course, the fact we don't have enough data is where you all come in, because it's our expectation that in your careers, you're going to be generating some of this data. Same with nutritional support. When I was a fellow, we just didn't let people eat. That's the red no sign up in the upper left. And then when they got hungry again, we gave them clear liquids in the middle there. And then if they drank the clear liquids, we gave them solid food. And then we began to worry that those patients were starving for too long. So we started TPN in the upper right. And then we realized that TPN was kind of risky. So we went to nasojejunal tube feeding in the lower right, where we put these long tubes down and we thought we could feed patients without stimulating the pancreas. And then people began to say, well, all you need is like a simple CORTRAC tube, like the one in the middle on the bottom row. And they do just fine with that. They don't seem to get worse pancreatitis. And then people said, well, you can just do an NG tube, the lower left. And then people said, well, if you're just putting nutrients in an NG tube, why not just let them eat? So now we're back to the same spot, which is that we keep them NPO until they feel like eating. And as soon as they feel like eating, we let them eat. We don't use the clear liquids too much anymore. We go right to solid food. But we really, during my career at least, we've come full circle in how we think about what's the right thing to do in managing these patients. Next slide. So another treatment goal I mentioned was, can we reduce inflammation or salvage the pancreas? There have been lots of attempts to do this, and I listed a number of attempts which have been utilized and studied over time: getting rid of digestive enzymes, resting the pancreas, inhibiting the systemic inflammatory response, and none of these have worked. So hence my picture of failure to launch. We don't have a specific therapy for acute pancreatitis that either reduces that systemic inflammatory response or limits necrosis. Next slide. It's interesting, though, when you look at the mortality from acute pancreatitis, obviously a very important outcome. And if you just looked at the data, which is presented in the lower right, we're doing better. So if you look at the case fatality rate in the 60s and 70s and 80s, it was in the 15 up to 20%. And if you look at the case fatality rate after that, it's less than 10%. But this all happened without any specific therapy for acute pancreatitis. So this is not because we introduced some specific therapy. This is due to just improvements in general medical care. So general, antibiotic stewardship, management of pneumonias, prevention of ventilator-associated pneumonia, prevention of nosocomial infections, line management, all that kind of stuff. So there was an improvement in overall care, and our patients benefited from it, I guess, even though we didn't have specific therapy. So that's good news, if you will. Next slide. So the other question is, if let's say we know what to do we actually do it? So we know that TPN is not helpful and it's often harmful. We know that prophylactic antibiotics don't work. So I'm thinking about when I teach a fellow endoscopy, I go through this process. Do they know what to do? So I present them with a scenario, ask them what they should do, and they give me an answer. And hopefully they know what the right answer is. And then if I'm in a clinical scenario that mimics that and we're doing endoscopy, I ask them to show me that they can do that maneuver, that procedure. But the question is, after they leave training and they're out there on their own, do they continue to do the right thing? So it's this know and show and do. So we know that although TPN and prophylactic antibiotics are not effective, they're still widely used. And so the question is, that's also part of making progress, which is implementation research. That is, if we know what to do and we're not doing it, why aren't we doing it? And can we design interventions that make us better at delivering the highest quality care? Next slide. So just a few thoughts about what we know and what we don't know about acute pancreatitis. Now, chronic pancreatitis. So here's a patient. And these are, both patients are my patients, are real patients. So this is a 32-year-old woman seen in clinic, an episode of pancreatitis during college, and then developed more chronic and persistent pain over the last few years. And a CT scan 6 months prior to this clinic visit shows pancreatic atrophy with scattered calcifications. The duct is 4 millimeters. She said she doesn't smoke or drink, but she did drink some during college. No known family history, no diarrhea, but a 5-pound weight loss. And the pain is significant. It's epigastric radiation to the back, and it's a moderate, but still tolerable level of 5 out of 10. So that's the patient. So some questions I might ask you. Do you believe alcohol causes pancreatitis? Would you order genetic testing? Would you order an MRCP? Would you recommend EUS with a celiac plexus block to treat the pain? Would you recommend an ERCP? Would you perform some screen for exocrine insufficiency or diabetes? Would you order a bone density test? Would you start treatment? And if so, what would you start treatment with? A gabapentoid, an opioid, an antioxidant, enzymes? So all the clinical questions I think each of us face when we see patients like this. And again, sometimes we don't know the answers to these questions. Next slide. So again, I did the same exercise for chronic pancreatitis. What I knew for sure when I was a fellow, that was always due to alcohol, and those who denied alcohol were just telling us a fib. And now we know all of these non-alcohol causes are much more common. I didn't worry too much about smoking in terms of the pancreas, and now we know smoking is just as injurious as alcohol to the pancreas. Back then, these patients came in with a painful flare and their amylase or lipase wasn't elevated, and we said, well, it can't be an episode of pancreatitis then. And now we know that's exactly what happens to these patients. With repeated attacks, these peak levels drop, and they present with severe pain in the absence of elevation of amylase or lipase. When EUS came out, we were very excited that it was going to be a way to diagnose early chronic pancreatitis, and as it turns out, it's too sensitive, too many false positives for accurate early diagnosis. We thought that nerve blocks should work, and now we know that nerve blocks and neurolysis don't work that well, probably because the pain has a central component. We didn't think there was anything we could do to delay progression, and now we know there are some things we actually can do, such as stopping smoking. And we didn't really worry too much about exocrine insufficiency, either about diagnosing it or treating it. And now we know it's common and it has important clinical consequences. And the same holds true for secondary diabetes from pancreatic disease. Next slide. And we have lots of guidelines in chronic pancreatitis like we do in acute pancreatitis. I include 2 here, and I can't blame anybody for this one because I'm one of the authors, and so is the following speaker, Dr. Whitcomb. And I'm not really pointing these out to talk about the specific recommendations, just the very last parenthetical comment for both these recommendations: strong recommendation, low quality of evidence. So in like acute pancreatitis, We have strong levels of opinions and recommendations, but the evidence upon which we base these recommendations is low quality. And this is consistent across pancreatology, acute and chronic pancreatitis in both adults and kids. Next slide. So these are just a list I thought of that if you're looking for a good area of research to focus on, these are some important unanswered questions and clinical needs. In acute pancreatitis, things like best practices for early management, interventions that preserve or salvage pancreatic tissue, prevention of progression, understanding the interplay between the exocrine and endocrine gland, and looking at outcomes that patients think are important, patient-reported outcomes, implementation research, improving adherence to best practices, studying health equity and delivery. Are we doing well across the entire spectrum of patients? And ultimately, precision approaches, which Dave Whitcomb is going to talk about. And similarly, for chronic pancreatitis, a number of areas that things like getting us together on consensus definitions. What defines worsening or progression of chronic pancreatitis, for instance? Reducing the stigma, this sense that everybody is an alcoholic that gets it. Early diagnosis, when we might be able to do something, and biomarkers to help us predict who's going to develop specific outcomes. Better diagnosis, more effective interventions, particularly opioid-sparing interventions for chronic pain. And in the pediatric world, prevention of progression, and if you can't prevent it, transitioning patients to adult life, important clinical needs. And then again, the ones I mentioned for acute pancreatitis in terms of patient-reported outcomes, better adherence to best practices, equity, and precision approaches. Next slide. One of the important things I also thought about when I crafted this talk is, well, if we know certain things, but we don't know others, why don't we know? What is it that keeps us from knowing the answer to a lot of those questions? Well, part of it is we don't have a complete understanding of mechanisms, and we don't have good disease models to figure that out. I would blame myself for lack of imagination and adherence to dogma. I think that's a problem for all of us. The lack of cooperation in large-scale clinical trials has limited the quality of the evidence, and part of this is just lack of agreed-upon definitions. And I love this quote from Daniel Borstein, one of the great thinkers of our of this country, who said, "The greatest obstacle to discovery is not ignorance; it's the illusion of knowledge." So that's one thing we all suffer from. I think we know what we know, but in fact, what we know is not true. And Don Rumsfeld was kind of getting close to that when he was talking about the known knowns, the known unknowns, and the unknown unknowns. But what I'm talking about are the known but wrong. So as we think about what we know and what we don't know, and we look to all of you to answer some of these important questions, don't get stuck in the same sort of, or run into the same roadblocks that we've been running into. Think about why you're not getting to the answer and do something about it. Next slide. And I just, Steve Pandal is going to talk about this, but one of the things I think is really important and that's starting to really be essential in this field is working in a group. And there are lots of groups that are out there. I listed a bunch on the left here, and larger groups. And working in these large groups helps overcome a lot of the problems I just mentioned in the last slide. So, and some of the things that they've identified are listed on the right, the important advances. So I'll finish there and just thank you for your attention.
Thank you very much, Dr. Forsmark. That was outstanding. I particularly like the motivation in trying to get more data and how we need to cognitively frame what we're missing here, and how we can move forward for the field, avoiding the things that we don't realize we don't know. Great, fantastic. And I love the historical perspective too. So at this time, we also have an outstanding speaker coming up next, who is Dr. David Whitcomb. And like Dr. Forsmark, he also pretty much needs no intervention. He's a professor of medicine at the University of Pittsburgh, and he also has trained generations of translational researchers, pancreatologists, gastroenterologists, and he's going to talk about today precision medicine and where we're going in the pancreas and how can we take what Dr. Forsmark outlined, where are gaps, and how can we go forward with this. So thank you very much, Dr. Whitcomb.
Thank you very much for the kind introduction, and I believe I need no intervention. What I'd like to do is talk about precision medicine. Where are we going? And the problem with precision medicine is that when this idea first came out, there was tremendous enthusiasm and many people raised their hands and claimed to be experts. They didn't know what they were talking about. They confused and muddied the field, but it's the correct way to go. And I'm going to show you why. Next slide. So the first problem is that pancreatitis is complex. We know that there's acute pancreatitis, which is common and unpredictable, as Dr. Forsmark said. Click. That there's recurrent acute pancreatitis. The trajectory and complications are important. There's early chronic pancreatitis, which is reversible damage, but you can't diagnose it. And then there is chronic pancreatitis, which is irreversible damage. Our goal is to minimize damage and retain or restore normal function. And so what I'm going to talk about today is some definitions and how to diagnose chronic pancreatitis, the issue of trajectory, mechanisms, and management. The first picture here is of a normal pancreas. The traditional diagnosis of chronic pancreatitis is irreversible morphologic damages. Clinically, there are signs of loss of function, such as endocrine and exocrine dysfunction and pain. The challenge is that early chronic pancreatitis features are non-specific. They overlap with autoimmune pancreatitis. Chronic alcohol use can cause some damage that is not due to actual chronic pancreatitis. Longstanding diabetes, obstruction, old age, all these things look like pancreatitis, but they're not. So we need to have a new approach. Now, we learned a lot from hereditary pancreatitis. This is caused by variants in the cationic trypsin gene shown on the right and the inhibitor SPINK1. And people that have this, 80% develop acute pancreatitis, half of them then develop chronic pancreatitis, and about 40% will develop pancreatic cancer. So this is the trajectory where acute pancreatitis starts first, then chronic pancreatitis, and then pancreatic cancer. And that taught us that there's actually a pattern of occurrence of these diseases that are all linked together. Next. Next slide. So what we see is there's often a progression, and usually a progression from acute pancreatitis to chronic pancreatitis. This is called the sentinel acute pancreatitis event. So about 1% of people with no pancreatitis have acute pancreatitis. About 20% or more get recurrent acute pancreatitis, and of those, there's a high rate to progress to chronic pancreatitis, although some people go directly from acute to chronic, and that may be because of the severity of the injury. Next. What we see is that the rate of progression after the first episode of acute pancreatitis is dependent on the etiology, where there's a much more frequent and rapid progression from acute to chronic pancreatitis in alcoholic. In idiopathic, which is mostly genetic, it's a little bit slower. And in biliary, if you remove the gallbladder and address the bile ducts, it is less important. But we also see that recurrent acute pancreatitis is the major driver of chronic pancreatitis. And so with the first episode of acute pancreatitis, it behooves us to understand the etiology and the driver and prevent recurrence. This required a new definition of chronic pancreatitis. Next. We put together this paper from an international group of experts, and we realized a good definition needs two components. The first is the common features, the characteristics, which is fibrosis, pain, strictures, calcifications, etc. But we also added the essence of chronic pancreatitis. It's a pathologic fibroinflammatory syndrome in individuals with genetic, environmental, and other risk factors who develop persistent pathologic response to parenchymal injury or stress. And this is very important because it allows us to distinguish true pancreatitis from other things that are not pancreatitis but have similar features. We are also put together a conceptual model to help us think about this that follows the progression from nothing to acute pancreatitis, the sentinel event, recurrent acute pancreatitis, and then we have a early chronic pancreatitis where there's features that are there that may progress to established and then end-stage disease. Next. So what this allowed us to do is to organize all of the environmental and genetic risk factors depending on where they are and what they do, and to understand the injury, inflammation, resolution, regeneration sequence, which is also important for developing pancreatic cancer. We also see that the end stages of C and D, such as fibrosis, endocrine insufficiency, diabetes, are not surrogates of each other. And if you take one, you're not going to be able to predict whether or not the person has any of the others. So fibrosis does not predict exocrine insufficiency, diabetes, or cancer. Thirdly, is that we really want to move the diagnosis from end-stage disease up until the very first episodes of acute pancreatitis so that we can make a diagnosis in time to do an intervention and try to understand the mechanisms for driving disease. So what we have also did is to try to understand what is the etiology and risk factors that together drive disease. So this is the Tiger O classification system, and there's now over 30 things that are known to contribute to pancreatitis in one way or the other, genetics being one of the most important ones. And there are over 20 genes or loci that work together in interesting ways to cause pancreatic disease. And this is actually very important. But what we realize is that most genetic information is useless in Western medicine. And that's why we need to move to precision medicine. So in Western medicine, we're used to look at pathogenic genetic variants. And these are really bad mutations that are sufficient to cause a Mendelian disorder, such as hereditary pancreatitis that we talked about previously, and cystic fibrosis that we'll talk about in a moment. Next. So what we actually see is a lot of genetic risk factors. So these are the ones you find in a GWAS study. So they're more often seen in cases than controls. They are common in the general population. They're often in non-coding regions of the gene, so they affect regulation rather than function. They're neither necessary or sufficient to cause a disease, and they're often linked to alcohol or smoking or other environmental factors. And the interpretation of these complex combinations is impossible when you're only looking at cases and controls. Next. So let's consider a person that finds out they have pancreatitis, and how do we think about how this person can be assessed? Traditionally, we'll do a case control study where you put them in a bucket of cases since they have disease, and then you can do a GWAS study, and what you find is there's a whole bunch of genes that are either more common in the cases because they're risk, or in the controls because they're protective. But what we're really interested in is what is going on in this individual person. And as I mentioned before, there are different specialized cells that may be inflammatory cells, Andersen cells, duct cells. Each of them are different machines, and they work together in different combinations. And so we can put the variants that are in each of these cells into either risk or non-risk and try to use a model of each individual case. And in this person, they may have immune cells that suggest they're going to be at risk of fibrosis. The Andersen cells have a SPINK mutation. The duct cells have a CFTR mutation and a GGT1, which affects the ability to respond to injury. And so this is extremely helpful because now we have specific mechanisms in specific cell types. Next. And this allows us to begin targeting treatments for the cells that are actually affected. Next. So that we can focus on fibrosis, on trypsin pathway, on CFTR. And if we can fix any of these, it may shift this person to having no signs or symptoms. And so this leads us to our management. Now, Western medicine is based on the germ theory of disease. This is one of my heroes, Louis Pasteur. Next. He really broke the paradigm of the old traditional medicine caused by bad humors and looked at case controls in order to understand these diseases. So this is based on population-based medicine and the germ theory of disease, where you look for a single factor causing a disease. It's driven by statistical association and evidence-based medicine, which is really randomized controlled trials and meta-analysis. And for genetics, it's Mendelian. One gene, one disease runs in the families. But this is only about 5% or less of the patients with pancreatic disease. Next. Instead, we need to switch to precision medicine, which looks at complex mechanism-based medicine, considering all the relevant variants in an individual person. It's informed by big data and complex genetics, but you can't understand it by just looking at buckets. You have to develop dynamic mechanistic models that simulate normal and abnormal phenomenon under a variety of conditions. So this is like you would use in engineering. It allows us to study dozens of variables in an individual person under 100 conditions to determine what's causing and driving the problem and what you can do to fix it. There's only a few examples of precision medicine that have gone to clinical practice, but some of them are used in oncology, and we're beginning to apply them to pancreatic disease. Next. Next slide. So the case of cystic fibrosis is very interesting. So cystic fibrosis has two severe mutations, which affects multiple organ parts, especially the lungs. We see it as an autosomal recessive, where it runs in the families, and we look at the lung disease, even though pancreas occurs beginning in utero and is the most sensitive organ for CFTR mutations. Next. We understand in the pancreas, it is in the duct cell. Next. And if we look at the duct cell is a machine that actually transports different types of molecules from the basolateral side into the lumen, and specifically bicarbonate followed by sodium and water. And so what we would need to do is calculate the effect of all the genes and other factors causing cell dysfunction, and we can simulate the effects of one or more interventions that can actually restore the system to normal. And so in the case where a person has pancreatitis caused by CFTR variants that alters the function of the duct cells, we know what to target in order to improve this person's life and prevent them from developing a disease that no one can cure. Next. So the people that have worked on cystic fibrosis have been able to classify the 2,000 genetic variants into 6 or 7 categories based on how much damage there is. And the ones that are common in pancreatitis actually cluster in a group in which there's alter expression, and these are targetable. We can actually improve the function of these cells so that pancreatitis can be prevented, even though the more serious ones that cause cystic fibrosis remain to be tested, so that we can actually begin targeting patients with these types of diseases. Next. So what is the utility of pancreatitis genetics? Well, we see that it's medically indicated genetic testing to determine the etiology of pancreatitis, if there's a family history, if it's a young onset, if it's idiopathic acute pancreatitis, recurrent acute pancreatitis, or chronic pancreatitis. And below, I've listed all of the expert reviews that have concluded that it is medically indicated, which also means that the insurance should pay for it. There's growing utility in building acinar cell models, duct cell models, looking at the effect of other systems such as dyslipidemia and the pharmacogenetics, which is also important in targeting therapy. Next. And finally, it's potentially useful in pancreatic pain. There's going to be some exciting papers coming out and a special focus of pain in a NIH sponsored pain seminar coming up this summer. So it's important in pain management, in cancer, and in prevention of diabetes. The genetics and disease diagnosis is also important. Next. So this is an example. In Western medicine, the disease diagnosis depends on the clinical pathologic definition and criteria. So you have to have signs and symptoms of the disease, organ dysfunction, an abnormal biomarker, and pathologic evidence of disease. By the time this occurs for chronic pancreatitis, it's too late. But genetics in a precision medicine model can improve the accuracy, moving it to the early chronic pancreatitis. It allows you to differentiate between pancreatitis and the other things that are not pancreatitis. It gives you mechanistic information as to which cell type is dysfunctioning and why. It defines the disorder prior to the end stage disease, and it actually improves the biomarker function in order to make the diagnosis. Next. So this is how it helps. What you can see in the next slide this is a diagram showing the prevalence of a disorder in a population and the predictive value of a biomarker. And this biomarker has a sensitivity of 85% and a specificity of 85%. If you take a general population, looking at the far left, the prevalence of a true disease in the population is low. Next. What this shows is that with a biomarker with an 85% sensitivity and specificity, the positive predictive value is extremely low, and it is more likely a person does not have the disease. Next. If the prevalence of the disorder is 10%, then the disease is unlikely. It's a predictions about 35% correct and 65% not correct. But if the prevalence is even 30%, next, now a moderately poor biomarker still has a high positive predictive value, suggesting to go on to the next step. So using genetics and other features to classify the patients into a population, a virtual population that has a high prevalence of disease, improves the accuracy of even poor biomarkers. Next. So the problem is that everybody that practices Western medicine is used to getting a genetic report that says, do you have a Mendelian disease or not? That's not what is needed. Next. What we need is clinical decision support that anticipates the effects of a variety of genes, both the Mendelian ones and the common ones, along with lifestyle and other factors, and then integrates that with the patient's state, their age, sex, other information, comes up with a model of disease, looks at the mechanism, how to diagnose it, the disease state, and then puts it together to provide guidance as to what is wrong and how to treat the patient. So what we really need is not a genetic report. We need a clinical decision support, providing clinicians information on what to do, not assuming that they're going to become geneticists because it's too complex. We need to be able to integrate this into models so that the physician can know what to do. So in summary, next. The traditional approaches to complex disorders using a case control model fails. Precision medicine is an alternative to the evidence-based medicine case control by being able to consider many variables under many conditions using dynamic models and guidance in individual patients. Next. Physicians want clinical decision support reports rather than traditional genetic reports. And if this is put together, then precision medicine will be valuable for early diagnosis, for patient classification and prognosis, for therapeutic decision making, and for management strategies in order to help prevent the development of disease that nobody can cure. Thank you. And by the way, for those that would like to work with me, I have a postdoc position open that starts in June on our T32. So let me know at whitcomb@pancreas.org if you want to take 2 years to work on some of this stuff with me.
Thank
John,
you very much, Dr. Whitcomb. That was an outstanding summary of how we can go forward and how we can try new approaches to studying pancreatic disease. So at this point in our Q&A panel, I don't think the fellows have interjected at all with any burning questions, but I may be wrong. Please feel free. We have plenty of time for questions. Please feel free to raise your hand and I'll address them. But while we're waiting for some of the fellows to get involved, so I have a question for Dr. Whitcomb about cystic fibrosis and the new drugs in the pipeline. That seems really exciting, and we can maybe use that as a model for other disease. Currently, a lot of the drugs in cystic fibrosis are helpful for lung disease and for gaining weight, but we don't know that they're helpful for pancreatic disease. So what new drugs do you see on the pipeline for pancreatic disease and cystic fibrosis?
Well, the CFTR enhancers actually have been used in patients with what we used to call atypical or mild cystic fibrosis, where they have some lung disease and have residual pancreas function and recurrent acute pancreatitis. There's been several case series and case reports in which these individuals treated with ifacaftor had remarkable improvement with the recurrent acute pancreatitis stopping and with some actual return of pancreatic function, so that the need for pancreatic enzyme supplementation, PERT, was reduced. The problem with these is that the current ones that are available are way too expensive in order to use for pancreatitis under that basis. But there are additional options that are on the horizon. So we're actually very excited about this. And there's other ways to improve duct function as well. So being able to target the organs, we're learning how to do that. And I think there's going to be a lot of progress in the next 5 years.
Great. Yeah, we will look forward to that. I also noted that you mentioned that you are studying lipid disease and hyperlipidemia as it affects pancreatic disease and modifies that. And that seems really exciting to me. I mean, it seems like our understanding of lipid problems is in basic high HDL, LDL, and triglycerides is extremely basic and just touches the surface. So how do you see, are you subdividing lipid problems into further categories?
Yeah, so there's a couple things very interesting. There was a recent paper that was published, Duraj Yadav was part of that, in Digestive Diseases and Sciences with a group, I think it was Kaiser. And what they showed is that individuals with even moderately elevated triglycerides between 200 and 500 had recurrent acute pancreatitis, and that turned out to be a significant feature. So we've been thinking about people that have these familial diseases where their triglycerides are in the 4,000 and 5,000 range. It turns out once you've had one episode of acute pancreatitis, it seems to prime your pancreas to recurrent episodes. And there's actually some really nice work coming out of Miklos Sahun-Toth's laboratory demonstrating this phenomenon in animals as well. So it's true, and we understand the mechanism of that. So the problem is that we don't look at the lipids, and understanding some of the genetic polymorphisms that predispose to it is also relatively in its infancy. The people that are lipidemic, that study lipids, have focused on the Mendelian disorders, but now what they understand is that it's almost all complex trait, and it's especially affected by diabetes and alcohol and obesity. So now the fields are merging, and what we've been looking at is patients with these genetic variants that affect triglyceride levels, and turns out that if you identify them and treat the lipid problem, their recurrent pancreatitis goes away. So we have some cases of that and are hoping to put a case series together. But that's been, sort of ignored, and it turns out to be important and maybe more common than we thought. Also, there's some exciting work coming out now that even the moderately elevated levels of lipid in acute pancreatitis, if the lipids are unsaturated, then they cause multi-organ failure, whereas saturated ones don't seem to do that. So the understanding of the mechanism underlying transition from SEERS to multi-organ failure may in part be due to lipids.
So I just wanted to reinforce one thing that David said there, which I think is essential, particularly as you're sort of, a fellow and thinking about you want to study in this field, that it's never just one thing, I think is my conclusion. It's never just gallstones. It's never just alcohol. It's never just smoking. It's never just lipids. It's never just genes. It's this combination of factors in an individual person, in an individual sort of environment, that triggers this. And so the complexity is daunting, but it's kind of interesting as we're starting to ferret out the various contributors. Once you understand what they are, then you can start to analyze their interrelationship. So it's quite an exciting time. But don't think about pancreatitis as sort of an event due to a particular trigger, because that's not accurate.
It'll be really exciting to see as we get artificial intelligence over the next few years and big data, how that contributes to all this. I think it's going to change our world.
We've used some artificial intelligence, and it's really challenging. What's really needed is just old-fashioned hard work to put it together. That's
some HI, some human intelligence to guide the AI.
That's what I was taught very early. Artificial intelligence will never replace real intelligence. Looks like we have some questions in the chat box.
Yes, in the chat box, Dr. Zafar Fayez comments that he has he's looked at etiologies of complications of pediatric pancreatitis, and he found that about 50% were idiopathic and 30% of acute were idiopathic. And now he's trying to look at the availability of genetics, and he sees SPINK1 as the most common mutation that he found in about 40%. And so that's great. We're glad you're working on that. Do our panelists have any comments on that?
No, it just made me thinking, David, maybe you can tell me so I can learn something here as well. I mean, how do you frame the idea of sort of dose effect when you're looking at genetics, and you're it's a mixture of genetic mutations, some stronger than others. How do you think about sort of the cumulative, I don't know, not dose, but the cumulative risk that a whole series of mutations imbues in an individual patient? Is there a sort of a framework you use to think about that?
Yeah, so I think the main thing we're doing is we're trying to break this down into acinar cell or a duct cell as where the injury is originating from. And then there's also, trauma, obstruction, cancers in the older patients, those kinds of things. But it's like many risk factors, they are there, but they're not really important until a certain event happens. So that the first episode of acute pancreatitis really triggers a cascade of events that we call it the sentinel acute pancreatitis event, where the pancreas is changed forever. And that allows us now to look at what kinds of combinations of things seem to be contributing to it, especially because there's always hidden variables and things we don't know about that seem to contribute from time to time. So this allows us to work on preventing recurrence and perhaps strengthening the pancreas's defenses if the person is deficient in different, vitamins or those kinds of things. And that's really what we're aiming at as well. So I think that's how we approach it. But there's, as Chris, as you showed earlier, age makes a big difference, sex makes a big difference as to the likelihood of one etiology or the other, and then those kinds of things are important. So we don't screen for cancer in children, but if you have new onset in your 60s, we're thinking about IPMN, duct obstruction, or some other things like that are triggering it.
Thanks.
Fantastic. Dr. Forsmark, not to change off the genetic topic, because that's a fantastic topic, but I'll go back to a little more practical consideration. I always have trouble. Lately, we've been moving more towards feeding folks with acute pancreatitis pretty early in the process. And I'd like to hear your general approach to feeding folks with acute pancreatitis.
Yeah, I mean, I think at the current time, I'm quite liberal. I allow the patient to eat or drink if they feel like eating or drinking, and if they have pain or discomfort or they don't want to do it, then that's fine. I don't force it, and I generally wait around somewhere in the neighborhood of 4 or 5 days to try to get a sense of whether if they're turning around and they're gonna start eating and drinking relatively soon, or if it's going to be a very prolonged stay. Typically the folks with the very prolonged stay, you kind of know that by that time they're in an ICU, maybe they're intubated, that kind of stuff, and you have to get them nutrition in some other way. But I think for most of us, I mean, the vast majority of folks, there's no downside to letting them eat or drink whenever they feel like it. It doesn't suddenly bring on organ system failure that they weren't otherwise going to have, and if it causes pain, they stop. So I'm quite liberal. Some have suggested that we should get away from the NPO order for a patient that's admitted with acute pancreatitis, and so anyway, I'm quite liberal. I don't know, how about at your institution, Dave? Same way, or do you have a different strategy?
I think it's pretty common. It really depends which service it is. Since we don't have a primary GI service, we serve as consultants, and we're often not consulted. So, it's a mixed bag, and we need better education and consultation. The one thing I'd add about acute pancreatitis, it's very interesting. We have been studying the transition from SEERS to multi-organ failure. And we just published a paper in American Journal of Physiology using a compartment model and those kinds of things. And it was fascinating because it turns out that SEERS is an important factor for developing multi-organ failure. The multi-organ failure requires a buildup of some toxins or something, but it doesn't occur until about 12 to 24 hours after the patient is admitted. And from that standpoint, we often see patients who were thought to have mild acute pancreatitis or a little bit of SEERS, and they didn't recognize that the transition to multi-organ failure is delayed. And so I just want to alert our fellows and junior faculty that you have to be vigilant with patients with acute pancreatitis, because the early presentation is a burning fuse that may or may not lead to an explosion. And so you got to watch them carefully, and there's a lot to learn about how to manage them in these time points. But I think there are some new biomarkers that really tip us off to the direction they're going. And it gives us a window of opportunity to intervene. We know what the timing is. We don't know what the intervention is. But this is something that I think is really going to make a big difference.
Okay, fantastic. Dr. Misum, you have a comment here.
Thank you, John. And thank you, David, Chris, and John. This is a very exciting kickoff session for this meeting. I'm so glad to see it finally happening. So I did have a comment actually on one of the questions in Dr. Whitcomb's talk on the types and the number of genes that could be involved and possibly affect the disease phenotype, because that is a very important question that was brought up. So from a limited study, I just wanted to elude from children. Then when we looked at a cohort who had acute pancreatitis, and we followed them for 5 years, and they did not develop a second attack. And then we had the same cohort who had a first attack pancreatitis within that time frame, and then went on to have the second attack and then CP during the 5-year follow-up that we had. We did an 8-gene panel, extensive workup for them to see that what is the role of genes that are involved in acute pancreatitis and affecting the progression from the first attack on. What we learned from that limited study, it had 110 patients, all pediatrics, was that genes were involved in the single attack that did not progress, and also were involved in the second and the ones who went on to have CP. Not that you have to test patients within first attack without a family history, but that was really from a research study for the fellows attending. And then the gene type did actually affect the rate of progression over time, with the strongest drivers were the PRSS1, CFTR, and the SPINK1 gene. So that's to our attendee who commented on that. Then the most fascinating result that came out of that, single center study was that when we had 0 genes involved from those 8, that group had the lowest rate of progression to CP over time. And if you had 1 gene involved, that was faster compared to the first group. And if you had 2 or more, those were the fastest over time. So that was really kind of nice to shape that we do need to test extensively when we have a patient like Dr. Forsmark presented, with a second or CP. I would test those patients because those tests have been really changing the management, because once we know that, it does cut the cost from other tests that people keep doing to find the reason. So I just wanted to throw in that to you all.
Yeah, those are great comments. And, the pancreas, what amazes me about it is how rigorous and robust it is and how it can protect itself. So if you're getting pancreatitis, something has to be going wrong. Mm-hmm. It just doesn't happen in patients that have a normal anatomy and genetics. There's something that has to go wrong, or you just don't get it. So it's a fascinating field, and I think we're learning a lot. And this next generation's got a chance to really change all the things that Chris and I were taught that were wrong.
Yeah, it really is a golden age, and folks that are on the call, I mean, you're coming in at a terrific spot where so much is on the horizon that's going to actually be useful for managing patients. So it's a wonderful time to be getting into this field, that's for sure.
There was a statement at a graduation that half of everything that students were taught was wrong, but they didn't know which half. What Chris and I learned was 90% was wrong, and the other 10% is suspect.
Yes, indeed.
Great, fantastic. And I would love to continue this panel further, but I think in the interest of true GI rounds and getting a little snack here for our East Coasters for lunchtime and getting a little break for our fellows, I think we'll end this panel, and we'll reconvene at approximately 12:30 for our second session. Thank you so much, everybody.
My Lord will lead me there soon. We'll meet, I know we'll meet beyond the shore. We'll kiss just as before. Happy we'll be beyond the sea, and never again I'll go sailing. No more sailing. So long, sailing.